Hi friends, so today we are going to discuss about pulmonary embolism. It is a very important entity in intensive care practice. Everybody should have thorough knowledge if you want to successfully practice intensive care. In this video, we are going to discuss about the approach to a suspected case of pulmonary embolism. We will discuss what diagnostic options that we have and what are the treatment modalities that we have. I have taken a lot of literature from mainly the European Respiratory Society guidelines from 2019 and also a recently published clinical practice article from New England Journal of Medicine. I am sharing the links to both these articles in the description of this video. I have taken some images also from these articles and I will mention that in the due course of the discussion. So let's go ahead and discuss pulmonary embolism. Now, what happens in pulmonary embolism? So, as you know, there are thrombi within the pelvic or deep veins of the legs, and these thrombi embolize and enter the pulmonary circulation. They, according to their size, they occlude certain levels in the pulmonary artery, and this leads to manifestations of clinical manifestations of pulmonary embolism. Most of the manifestations are because of the pulmonary infarcts or right heart failure. Generally, this is an acute process, and if you see here, you can see that there is sudden increase in the afterload for right ventricle. Right ventricle cannot compensate that afterload and it fails. Sometimes there is a chronic process, and on top of that there is an acute insult, which you can see here. So if there is a chronic ongoing process of pulmonary hypertension, there is volume overload first. Right ventricle, as you know, is a thin walled cavity. It has more capacity to dilate, so initially it dilates to maintain the stroke volume. Beyond certain point, there is pressure overload as well, and this leads to tricuspid regurgitation, as well as pushing of the septum, interventricular septum, towards the left ventricle side. Both of these things are harmful because there is this further worsens the right heart failure. Right ventricular output is impaired because the septal component which contributes to the output is impaired. At the same time, left ventricular filling is impaired because the left ventricle size becomes smaller. And eventually this leads to cardiovascular collapse. There is also stretching of the right ventricle muscles, and this leads to increased oxygen demand, which is not met because of the pulmonary hypertension. The perfusion of the right ventricle gets affected, PVR goes up and SVR remains the same. So the perfusion mainly happens because of higher SVR, which is not there in this case. This leads to right ventricular ischemia and right ventricular infarct. Friends, I have taken help from the European Respiratory Society guidelines from 2019 and one of the recent article published in New England Journal of Medicine for clinical management of pulmonary embolism. I am sharing the link of both these articles with you in the description of this video. Now, before we go ahead and discuss the diagnostic approach, we must familiarize ourselves with various scorings. You will ask, what are the scorings? And in my training days, I used to get very confused because there is an exhausting list of scores: Wells score, modified Wells score, Geneva score, revised Geneva score, simplified Geneva score, year score. These are various scores which are given, which are formulated to make an estimation of clinical probability of pulmonary embolism. Generally, if the patient is fulfilling certain criteria, the scoring is given based on that. You can see various scores in your literature, in the standard textbooks. You can find them on the internet also, you can find them. The important score, in my opinion, is one is Wells score and one is revised Geneva score, which both can be seen here on the screen. Generally, these scores take into consideration factors which are likely to be present in pulmonary embolism. So these factors include tachycardia, varying extents of tachycardia, whether there is hemoptysis, whether there is evidence of deep vein thrombosis, redness, warmness, tenderness on the calves, the background of the patient, like malignancy in the background, or surgical patient, bed-bound patients. All these are taken into account, and based on that, the scoring is made. Year score is a very simplified format where they have taken three important factors from the Wells score. Year score include whether there is a high possibility of pulmonary embolism compared to other differential diagnosis. That is first point. Second point is whether this patient has hemoptysis, and third point is whether this patient has evidence of deep vein thrombosis. And if one of them is present, then it raises the possibility of pulmonary embolism. We will see in the flowchart how to utilize these prediction scores, and based on that, how to go ahead in our treatment. Now, clinically, if you see that any patient is acutely breathless, probably there are 4 or 5 main differential diagnoses here. One of them is pulmonary embolism, obviously, since we are discussing this. But apart from that, the patient may be having pneumonia, there may be acute exacerbation of COPD or asthma, patient may be in cardiogenic pulmonary edema, or there may be a tension pneumothorax, which might have led to acute hypoxia. Now, you have to apply your brain, look at the various signs on the patients, take history, and then think whether there is a probability of pulmonary embolism in this patient, or we have other possibilities which are more likely. There can be a situation where all these can coexist as well. So please remember that. And in this situation, when you are having a suspicion, the probability scores come handy. So I would say you can use revised Geneva score. Probably I have used it more often than other scores, but you use these scores, and based on the various points that are given, you come to know whether there is a high probability of pulmonary embolism or whether there is low to intermediate probability of pulmonary embolism. Now this is very important step, because at this step, whether you are in low or intermediate versus high probability, your investigations are going to change. So now, suppose you are having a low probability of pulmonary embolism, low or intermediate, then at this stage you do D-dimer test. D-dimer is a very commonly used test. It's a non-specific marker actually. It can be raised in prolonged hospitalization, inflammatory conditions, cancer patients, post-operatively severe infection. Even in COVID also D-dimer tends to rise. So it's not really specific for pulmonary embolism. However, in low probability state, it is a very sensitive marker to eliminate possibility of pulmonary embolism. So you can use D-dimer to exclude pulmonary embolism. Generally, if you see the literature, generally the consensus so far was that if the D-dimer score is less than 500, then that rules out pulmonary embolism. But recently, in recent years, the guidelines have changed. There is more evidence, and now we feel that we have to follow manufacturer recommended D-dimer levels rather than an arbitrary value of 500. And we have to take into consideration the age also. General formula is age into 10 is the cutoff for the particular patient. This applies for patients who are elder than 50 years. So if, say, patient is 70 years, his D-dimer cutoff for pulmonary embolism, for ruling out pulmonary embolism, will be less than 700. That's the new guideline which is suggesting this. Now, if you are using years score, which is one of the probability score that we discussed, if the patient has none of the years score out of 3, none of the factor is present, plus D-dimer is less than 1000, you can safely exclude pulmonary embolism based on one study. You can also, if the year score is, one of the year score is positive, but D-dimer is less than 500, then also you can rule out the pulmonary embolism. However, if you have a high probability of pulmonary embolism, then we don't do D-dimer in these patients. Even if it comes high, we don't get any information. If it comes low, we can't exclude pulmonary embolism because there is high clinical probability based on the scoring that you performed. So doing D-dimer in a high probability setting is not advisable. Please bear that in mind. So what do you do in high probability? So if the patient has high probability, you do CT pulmonary angio. That is your first line of investigation. If you are in low probability or intermediate probability and your D-dimer is positive, then also the next step is to do CT pulmonary angio. It is a very quick test, but you have to take the patient obviously to the CT scanner. So if the patient is very unstable, sometimes it may not be possible. So you have to keep that in mind. Patient is exposed to radiation, patient is exposed to contrast. There is a risk of allergic reaction to contrast-induced nephropathy. All these risks are there, but if the probability is high, it is worthwhile considering doing the CT pulmonary angio. There is also a possibility that sometimes you may overestimate the diagnosis of pulmonary embolism by a small margin. This is especially true for the subsegmental pulmonary emboli, and we don't know clinically what is the implication of these. So that is something which you have to take with pinch of salt. But CT pulmonary angio is a very good investigation for main branch or segmental thrombi. It is an investigation of choice, I would say. The other investigation like SPECT or VQ scan or digital subtraction angiography, these are all not very practical in most of the situations, but for the sake of completion, we are discussing that these are the other options. DSA angiography is probably the historic gold standard because you are actually seeing everything very well. but you have to remember that more radiation and more contrast is given to the patient, and that's not very desirable. So that's about the CT. Transthoracic echo is very important diagnostic tool. It is useful because when you can't shift the patient for CTPA or you don't have facility for that, it is a bedside tool, and you can have very specific signs which help you diagnose pulmonary embolism. It is one of the accepted modalities if you want to diagnose pulmonary embolism and your patient is hemodynamically not stable. Along with the diagnosis of PE, you can also look at the various other structures of the heart, and you can diagnose the cause of shock, which may not be PE. Sometimes there may be coexisting other pathologies which you can diagnose with your transthoracic echo, like LV dysfunction, valvular pathologies, pericardial pathologies, tamponade, etc. So it is a useful tool, and you must know at least critical care echo, which may be useful in your practice. What signs will you see on transthoracic echo? So in apical view, you will see that the right ventricle is prominent. If you look at measure at the base, the right ventricle will be equal or larger than the left ventricle. Typically, there is a sign described as McConnell's sign, where the right ventricular apex is contracting, but the free wall is not contracting. This is also in apical view, and you can suspect that this patient may be having PE. Now, if you go to parasternal long axis view, you can see prominent right ventricle. If you can go to parasternal short axis view, you can see that the septum has become flat and it is pushed towards the left ventricle. Typically, the left ventricle looks round like this, but if the septum is pushed, it becomes flat and the left ventricle looks like D-shaped. So that is another important sign which might give a clue that there may be a pulmonary embolism. Now, if you look at the subcostal view, you can see prominent inferior vena cava and very little or no movement during the respiration. So that also indicates back pressure changes, and it may be because of the pulmonary embolism. If you go into more advanced echocardiographic findings, there is a sign called 60-60 sign, where the peak acceleration time at the pulmonary valve is less than 60 millisecond, along with the coexisting with the systolic gradient at the tricuspid valve. Also, it is less than 60 milliseconds. So there is only mild systolic gradient along with the reduction in peak acceleration time. So this is called 60-60 sign. If you can do a TAPC. TAPC is when you run M mode in apical view at the tricuspid valve. It's called tricuspid annular plane systolic excursion, and typically in pulmonary embolism, it is less than 16 millisecond. If you run tissue Doppler in apical 4-chamber view at the level of tricuspid annulus, then you notice that the velocity of tricuspid annulus, you will find it going down less than 9.5 millisecond. So that's the TAPC and your velocity of tricuspid annular movement. So these are the advanced signs. So based on these signs, you can make a educated guess that this patient is most likely to have pulmonary embolism. If you can demonstrate a thrombus at the level of tricuspid valve, which you can see in the image in one of the patients we got it, then it is entirely certain that this patient has pulmonary embolism, because some part of the thrombus would have already dislodged, and this may be the remaining part. And if not, this part will dislodge into the pulmonary circulation anytime. So this is like a ticking bomb, and it is associated with very poor outcome and high mortality. Now, if the patient has pre-existing pulmonary hypertension, what changes you will see? So probably you will see that the right ventricular wall thickness is more. This is because the changes of pulmonary hypertension take place over time, and this gives some time for the right ventricle to dilate, to develop some hypertrophy of the musculature, and then on top of that, the patient may have had some other problem. So if the ventricular wall thickness is high, that is a sign that this might be a chronic change, and then you may not, with confidence, you may not be able to diagnose pulmonary embolism. So this is about 2D echo. Now, you also have got option to do compression ultrasound. So in acute situation, you do 4-point compression ultrasound. So you do compression ultrasound at both the groins for femoral and both the popliteals at the back of your knees. And if you find thrombus at any level, and if it shows failure to compress the veins, that is a very reliable sign that this patient is likely to have pulmonary embolism as well, because you have demonstrated a DVT, and in that clinical context, the patient is most likely to have a pulmonary embolism. So compression ultrasound is fairly easy and a reliable tool, and you can definitely use that. If you can't find anything on compression ultrasound, then it does not mean that you have ruled out pulmonary embolism. So keep that in mind. It is very specific, but it is not sensitive. So you cannot rule out pulmonary embolism with compression ultrasound. So that's about the diagnostic approach. Imaging wise, now if you do an ECG for this patient, you may find new onset right bundle branch PROC, you may find right ventricular strain, you may find even right ventricular infarction. if you send blood investigations like cardiac markers, troponin I and BNP, these are likely to be raised in massive or significant pulmonary embolism, which is affecting the hemodynamics. So these are useful adjuncts, and they may give you some idea whether this patient is having right heart dysfunction because of pulmonary embolism, along with your echo. And these patients sometimes are candidates for thrombolysis. Now we will discuss the treatment approach for these patients, and for that we have to stratify them into various risk groups. So it is high risk, intermediate high risk, and low risk, and this you can do by PACE or simplified PACE, which is Pulmonary Embolism Severity Index. You can see PACE here, you can see simplified PACE here. I generally prefer simplified PACE because it is very simple and easy to remember. If the score is more than 1, so 1 or higher, then that means the patient is into high or intermediate group. If the score is 0, that means the patient is low risk. PACE is also useful for prognostication. The higher the score, the worse the prognosis. So that's PACE. Now, if your patient is hemodynamically unstable with acute drop in blood pressure of 90 or less systolic blood pressure, or drop of more than 40 millimeters of mercury in blood pressure, probably this is a sign that the patient is hemodynamically unstable. If the patient has signs of shock, we have discussed shock and hypotension in various videos in the past. Please go through them for more details about that. So if the patient is in shock or hemodynamically unstable, that means the patient is very high risk and requires reperfusion therapy. If the patient is hemodynamically not unstable, but there is some evidence of right-sided heart, right ventricular dysfunction, or right ventricular stress on the echo, then you have to send cardiac markers like TROP-I and BNP, and if they are elevated along with right ventricular dysfunction, then that patient is intermediate high risk, and this patient also may require thrombolysis. Generally, we don't thrombolyze straight away these patients, but if they deteriorate, we may have to consider reperfusion therapy for them. If the patient is not having any hemodynamic instability and the right ventricle is also functioning reasonably with the markers in normal range, then this patient is a low risk patient, and if it is feasible, this patient can be managed even on outpatient basis. But the high risk patient has to be admitted in the ITU. The intermediate high risk patient may be admitted in the ICU or HDU in the initial time, and if remains stable or improves, you can step down. If worsens, you can admit in the ITU for reperfusion therapy. So that's the broadly the plan of treatment for these patients. Now, what are the treatment options? So we will discuss them one by one here. So treatment wise, there are 3 main strategies: supporting the cardiac and respiratory system, anticoagulating these patients, and reperfusion therapy. In one of my previous videos on right-sided heart failure, I have discussed in great details about how to support failing right heart in terms of cardiovascular and respiratory support. So please go and see that video if you haven't seen already. Regarding anticoagulation, so every patient with pulmonary embolism needs to be anticoagulated. Now, whether it is in the ICU, whether it is in the ward or home based, depends on our risk stratification, which we recently discussed. Drug of choice for anticoagulation in these patients is low molecular weight heparin. Fondaparinux is a reasonable choice. They are both associated with less bleeding if you compare them with unfractionated heparin, and also they are not associated with heparin-induced thrombocytopenia. Only where unfractionated heparin can be used is probably a situation where you have to give you have a risk of bleeding as well, like an immediate surgical, post-operative surgical patient. So you may start unfractionated heparin as an infusion and monitor the PTT, and if at any point patient bleeds, you can stop it, you can reverse it with antidotes, and for initial few days you can start with unfractionated heparin and then switch to low molecular weight or fondaparinux. For maintenance therapy, I mean for first 3 months after the initial therapy is started, the drug of choice is direct oral anticoagulants. So these include your apixaban, edoxaban, rivaroxaban, dabigatran. These are the commonly used agents. They have some different pharmacokinetic properties and pharmacodynamics. The dosing is obviously different. So in this chart, you can see the various options that you have. You can see their doses and other considerations. You can pause the screen and look at them. Now, suppose you also have option to continue with low molecular weight heparin. Probably enoxaparin is the safest agent, and this is for the set of patients who are pregnant, because direct oral anticoagulants and your vitamin K antagonist are both not permitted to be used in pregnancy. So only in pregnancy you will use low molecular weight heparin for longer time. Vitamin K antagonists are very cheap alternative, but you have to monitor the INR in therapeutic range, and you have to watch for various drug interactions with food interactions and this kind of things. So they have taken a back step in terms of choice of oral anticoagulants, but in certain conditions there is no other alternative but to use vitamin K antagonist. These conditions include significant liver and kidney dysfunction, patients who have history of arterial thrombi, patient with antiphospholipid syndrome who are triple positive. Probably these are the patients where vitamin K antagonist can be used. In literature till a few years back, cancer patients also, low molecular weight heparin was to be used for a long-term anticoagulation, but recent data has proved that direct oral anticoagulation, they are a good alternative to low molecular weight heparin, and they can be used safely even among cancer patients. So that's about the choice of anticoagulation, the initial choice and the initial 3 months of treatment. Now, what is the duration of treatment for your patient with pulmonary embolism? So duration is obviously at least 3 months, and the duration may extend based on various factors. So if your pulmonary embolism was provoked, say by surgery or immobilization, then probably once the provoking insult is stopped, after 3 months of anticoagulation, you may stop your anticoagulation. If your pulmonary embolism was not was unprovoked, in that case, or if it was provoked by cancer and the cancer is still active, or whether there is an antiphospholipid syndrome or some prothrombotic condition, then in that patient probably you will need to give longer duration of anticoagulation beyond 3 months. Sometimes the thrombus load is huge because of the massive nature of the pulmonary embolism. Sometimes the patients have residual symptoms, cardiorespiratory symptoms of pulmonary embolism, and in these patients probably it's better to continue with the therapy beyond 3 months. But like we discussed with cancer, with thrombogenic state or with unprovoked thrombi, these patients do not require full dose anticoagulation beyond 3 months. So after 6 months of therapy, you can come down on the dose of anticoagulation for these patients, and this has shown to be better than low dose aspirin, which was a practice a few years back, and it is as good as full dose anticoagulation. So probably you can go with low dose anticoagulation in massive pulmonary embolism and in patients with residual symptoms beyond 6 month period of anticoagulation. If the pulmonary embolism was unprovoked, then it is a good practice to screen for any cancers, and in certain percentage of population, clinicians have succeeded to find out a cancer, and the cancer has to be then treated. If you can't find any cancer, then probably there may be some other cause, but always in unprovoked pulmonary thromboembolism, find out whether the patient has cancer. Also, when you discuss with the patient and decide that this patient will have prolonged anticoagulation, review this patient first every 3 months for first year, and then yearly, and evaluate the risk of developing thrombi versus risk of bleeding, and discuss with the patient. Take the patient's input also into consideration regarding the long-term anticoagulation. So that's about anticoagulation. Now coming to reperfusion. So reperfusion strategy is generally, there is no timeline as there is for the myocardial infarction or stroke, but it is always advisable to start reperfusion within first 48 hours of symptoms if you diagnose the pulmonary embolism, or at least up to within 14 days of initiation of symptoms. For reperfusion, thrombolytic systemic thrombolysis is probably the most commonly used modality here, and you have various options like alteplase, which has been used over 2 hour infusion. You have alteplase to be given in a shorter duration, and you have tenecteplase, which has to be given weight based and a single rapid bolus. So all these three are good alternatives to each other. If you have cost constraints, then probably you may have to use streptokinase or urokinase, but they are not as effective as the other three that we discussed before. Now, apart from thrombolysis, you have other options like catheter guided therapy, and if you can pass a catheter near thrombus, you can do either fragmentation, mechanical thrombosuction, or low dose thrombolysis for that particular area. So that is a suitable option. If your center is equipped with that option can be practiced, although it has not come into full recommendation because there is very limited evidence, and there is fear that there is publication bias. They don't publish the unsuccessful cases. So you have to take it with pinch of salt. There is also option of doing surgical embolectomy, which is suitable only in advanced centers where thrombolysis is not possible. You may have to go for surgical embolectomy. But you have to have good surgical support and intensive care support for that. IVC filter has very limited role in usual practice. Routinely, they are not recommended. They have to be used only if your patient has absolute contraindication for thrombolysis, or if the patient, in spite of being on full anticoagulation, is developing recurrent thromboemboli. Now, we also need to know two important entities which are seen in long term after an acute pulmonary embolism. These are one is post pulmonary embolism syndrome, and second is chronic pulmonary thromboembolism. So, in post pulmonary embolism syndrome, those patients who have already got pulmonary or cardiac comorbidities, sometimes they continue to suffer from features of right heart failure or features of breathlessness, and in spite of optimum anticoagulation, they don't improve symptomatically, and that is described as post pulmonary embolism syndrome. Generally, based on the data, it is not associated with the initial load of the thrombus, rather it is associated with your coexisting cardiovascular symptoms, and these patients require chronic cardiopulmonary rehabilitation and obviously they require anticoagulation as well. Now, chronic pulmonary thromboembolism is an entity where beyond 3 months of acute pulmonary embolism, there are still some residual thrombi which have not cleared completely, and there is pulmonary hypertension and right ventricular failure secondary to them. So, to diagnose that, ventilation perfusion scan is the investigation of choice. And if you diagnose ventilation perfusion mismatch, then you do a right heart catheterization. And if the pulmonary artery pressure is more than 25 millimeters mercury with pulmonary capillary wedge pressure of less than 15, then these are the cases where you say that they are having chronic pulmonary thromboembolism. You can also do CT scan and you can see ring-like lesions or slit-like lesions, but CT scan is not the first line of investigation for these patients. Now, generally these patients do well with surgery, and mortality rate is around less than 5%, but they have to be managed by expert centers, and the centers are very limited. These patients have to undergo surgical endarterectomy, which is a major surgery. Many patients eventually end up on ECMO post-surgically for support, and sometimes they have to undergo lung transplant, like an emergency lung transplant for persistent pulmonary hypertension. So it's a really serious kind of problem, and the treatment is also very specific, and it needs specialized centers for that. In those patients who are not candidates for surgical treatment, balloon angioplasty may be tried, but the success results are variable. And in either of the cases, these patients generally require very long-term anticoagulation, sometimes lifelong anticoagulation, and vitamin K antagonists are the drug of choice in this situation. Dual direct oral anticoagulations haven't been approved for use in this situation. So if you have liked this video, please subscribe to my channel. Please hit like button, hit the bell icon to get notifications when I post new videos. If you have any suggestions about any topics or anything that I can improve, please post in the comments, and I will try to incorporate in my next videos. Till we meet for the next time, goodbye.